Hello there. Now we'll go ahead with rheumatology, and now we have a scenario where there is a 45-year-old woman complaining of pain in her hands, precipitated by exposure to the cold weather. She also has got breathlessness on walking. When she eats, she can feel food sticking to her throat, and she finds it difficult to swallow. It is usually relieved with a drink of water. So, what is the single most likely cause of her dysphagia? So, this is a case of systemic sclerosis, and diagnosis is quite clear here. Systemic sclerosis may present with pain in hands when exposed to cold, that is Raynaud's phenomena, and there can be shortness of breath due to pulmonary fibrosis and dysphagia due to esophageal dysmotility. So we have to remember these three things in systemic sclerosis. First is Raynaud's phenomena, that is pain in hands due to cold exposure, and breathlessness or shortness of breath due to pulmonary fibrosis. So second thing is pulmonary fibrosis causing shortness of breath, and third is esophageal dysmotility. Esophageal dysmotility can lead to dysphagia. So, systemic sclerosis is one of the causes of dysphagia, and other features of CREST syndrome may also be present, namely calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. So, as well as esophageal dysmotility, the lower esophageal sphincter pressure is decreased here. This is in contrast to achalasia, where the lower esophageal sphincter pressure is increased. Here, along with esophageal dysmotility, the lower esophageal sphincter pressure is decreased, in contrary to achalasia. So we have to remember one thing, that if there is involvement of lungs, it is systemic sclerosis, but in CREST syndrome, there is no involvement of lungs. In CREST syndrome, lung involvement is not there. So that's how we can differentiate it from CREST syndrome. But we have to remember that there is Raynaud's phenomena, there is pulmonary fibrosis, there is esophageal dysmotility, and it is one of the causes of dysphagia. Whereas in CREST syndrome, we have calcinosis, we have Raynaud's phenomena, we have esophageal dysmotility, sclerodactyly, and telangiectasia. So these are the things, and let's go through the chart which is given here. Now, systemic sclerosis, it is an autoimmune disease with increased fibroblast activity leading to abnormal growth of connective tissues, as we can see here. So, autoimmune disease with increased fibroblast activity leading to abnormal growth of connective tissues. So it is of two types, limited scleroderma and diffuse scleroderma. Limited scleroderma is CREST, that is calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. Whereas diffuse scleroderma, in diffuse scleroderma there is rapid onset and it involves trunk and limbs. There is thickening of skin, Raynaud's phenomena, and scleroderma renal crisis. So in diffuse scleroderma, we have a rapid onset and it involves trunk and limbs. There is thickening of skin, there is Raynaud's phenomena, and scleroderma renal crisis. Now the investigations which we carry out are, which are only valid in diffuse scleroderma. These are anti-SCL70 for diffuse, ANA for both, anti-centromere antibody, which is limited. So again, it is an autoimmune disease with increased fibroblast activity. Systemic sclerosis is an autoimmune disease with increased fibroblast activity, leading to abnormal growth of connective tissues. Two types: limited scleroderma and diffuse scleroderma. Limited scleroderma is CREST syndrome. CREST involves calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. And diffuse scleroderma, it is having rapid onset, involves trunk and limbs. There is Raynaud's phenomena, thickening of skin, and scleroderma renal crisis. Investigations are ANA, which is for both, and anti-SCL70, which is for diffuse, and anti-centromere antibody, which is limited. Now let's see the difference further between limited and diffuse variety of systemic sclerosis, or scleroderma, rather say. Now, as we studied, limited scleroderma is CREST syndrome, whereas another variety is diffuse scleroderma. Now, when we talk about skin involvement, in limited scleroderma, there are limited areas of skin which are thick, usually just the fingers and face. Skin involvement does not extend above the elbow or above the knee, so there is no involvement of trunk. Whereas in diffuse scleroderma, more areas of the skin are involved and thickened. Skin of both trunk as well as limbs, arms, and legs are all likely to be involved. Onset: limited scleroderma CREST syndrome has slow onset, diffuse scleroderma has rapid onset. Progression: CREST syndrome has slow progression, diffuse scleroderma has fast progression. Length of skin changes from Raynaud's phenomena. Raynaud's phenomena is for many years before any skin changes, whereas in diffuse scleroderma, skin changes occur within 1 year of Raynaud's phenomena. Now, organ involvement. Organ involvement, milder form in CREST syndrome, or talking about organ involvement. So in milder form of CREST syndrome, there is less involvement of body organs, and lung involvement can be seen, but usually very mild and less common. Whereas organ involvement in diffuse scleroderma is more severe type. There is involvement of internal organs like GIT, kidneys, heart, lungs, etc. In CREST syndrome, we have calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, telangiectasia. Whereas in diffuse scleroderma, the skin can lose or gain pigment, making areas of light or dark skin. Talking about antibodies, both of them may have positive ANA, but in CREST syndrome, antibody to SCL70 are usually negative, whereas antibody SCL70 are usually positive in diffuse scleroderma, up to 60% of the patients. Anti-centromere antibody ACA is positive in CREST syndrome. Anti-SCL70 is strongly associated with lung fibrosis and with renal disease and a poor prognosis. Found in 60% of the patients with diffuse scleroderma. So again, two types, limited and diffuse. Limited, also called as CREST syndrome. In this, there is calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly and telangiectasia, and skin involvement. In CREST syndrome, limited areas of skin are involved, which are thickened, and it usually involves limbs but not trunk. Trunk is not involved. It will affect up to the elbow and up to the knee joint, not beyond that. Whereas in diffuse scleroderma, more areas of the skin are involved, which are thickened, and involves both trunk as well as limbs, that is arms and legs. Onset, CREST syndrome slow onset, diffuse scleroderma rapid onset. Progression, CREST syndrome or limited scleroderma, We have slow progression, diffuse scleroderma, rapid progression, fast progression. Now, length of skin changes from Raynaud's phenomena. Raynaud's phenomena for many years before any skin changes. So skin changes take a long time to develop after Raynaud's phenomena and Crest syndrome, whereas in diffuse scleroderma, skin changes occur within 1 year of Raynaud's phenomena. Organ involvement, usually lung involvement is very mild and less common in Crest syndrome, whereas and there is milder involvement of body organs, whereas in diffuse scleroderma the involvement is more severe and it involves GIT, heart, lungs, kidneys, etc. Now, in diffuse scleroderma, the skin can lose or gain pigment, making areas of light or dark skin. Whereas in Crest syndrome, we already studied it includes calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. Antibodies ANA are positive for both. Whereas anti-SCL70, these antibodies to SCL70 are positive only in diffuse scleroderma, not in limited scleroderma or Crest syndrome. Anti-centromere antibody positive for Crest syndrome. Now anti-SCL70, which is positive for diffuse scleroderma, found in 60% patients. It has strong association with lung fibrosis, renal disease, and poor prognosis. So this is about systemic sclerosis. It is a multi-system autoimmune disease in which there is increased fibroblast activity resulting in abnormal growth of connective tissue. This causes fibrosis as well as vascular damage. Fibrosis occurs in skin, GIT, heart, lungs, and other internal organs. Vascular manifestations include Raynaud's phenomena, ischemia of extremities, pulmonary artery hypertension, and renal disease. So we have got other facts here. Patterns we already studied: limited scleroderma, limited systemic sclerosis, and diffuse scleroderma, diffuse systemic sclerosis. Another quick fact here is common conditions with Raynaud's phenomena are SLE, systemic sclerosis, rheumatoid arthritis, dermatomyositis, thoracic outlet obstruction, Buerger's disease, PRV, cold agglutinin disease, thrombocytosis, and hypothyroidism. So let's move ahead now. Now, a 63-year-old man presents with muscle weakness. He finds it difficult to walk for long periods of time or climb stairs. Activities such as rising from a seated position is difficult. He also finds difficulty in swallowing foods. ALP 149, AST 37, ALT 44, creatinine kinase 440, ESR is 16. What is the single most likely diagnosis in this case? So here we have a case of polymyositis and we'll be studying about it. The two top differentials here one should think about is polymyositis and polymyalgia rheumatica. Polymyositis and polymyalgia rheumatica. Now, proximal muscle weakness and raised creatine kinase points towards polymyositis. Proximal muscle weakness and raised creatine kinase indicates polymyositis. ESR is elevated only in 50% of the cases in polymyositis, but it correlates poorly with disease activity and response to therapy. So in this question, ESR is not elevated enough to consider polymyalgia rheumatica. Also in polymyalgia rheumatica, creatine kinase would not be raised. One of the criteria for the diagnosis of polymyalgia rheumatica is having an ESR of more than 330, CRP more than 6, of which we do not see. Hence the best answer is polymyositis. So we have to understand that proximal muscle weakness and raised creatine kinase, these two features, proximal muscle weakness and increased creatine kinase, raised creatine kinase, these two are features of polymyositis. In polymyositis, there is proximal muscle weakness and increased raised serum, raised creatine kinase. Now, ESR is elevated only in 50% of the patients with polymyositis. Now, talking about polymyalgia rheumatica, for the diagnosis of polymyalgia rheumatica, one of the criteria is ESR more than 30 and CRP more than 6. ESR more than 30 and CRP more than 6, which is not the case here. And also in polymyalgia rheumatica, creatine kinase would not be raised. Therefore, due to all these reasons, we are more inclined towards polymyositis as compared to polymyalgia rheumatica, because for that ESR should be more than 30, CRP should be more than 6, and creatine kinase is not raised in polymyalgia rheumatica, whereas in polymyositis we have proximal muscle weakness as well as there is raised creatine kinase. Let's study more about polymyositis and see if we have a chart on this as well. Yes. So talking about polymyositis, clinical findings. First, presents with difficulty with tasks which involve proximal muscles, that is lifting objects, combing hair, getting up from the chair. Weakness is usually symmetric and diffuse. So weakness is usually symmetric and diffuse, involving the proximal muscles of the neck, shoulders, trunk, hips and thighs. The lower limb muscles tend to be clinically symptomatic first. Third, fatigue, myalgia, and muscle cramps. So these are the features. First, presents with difficulty in tasks which involve proximal muscles like lifting objects, combing hair, getting up from the chair. Then weakness is usually symmetric and diffuse, and it involves the proximal muscles of neck, shoulder, hips, trunk, thighs. Lower limb muscles tend to be clinically symptomatic first. So lower limb muscles are affected first as compared to upper limb. Uh, Lower limb muscles tend to be clinically symptomatic first. Then third feature is fatigue, myalgia, and muscle cramps. Now talking about investigation in polymyositis, there is elevation of creatine kinase. Aldolase levels may also be raised. Autoantibodies, anti-Jo1, anti-Jo1 antibodies. Note that these are common in patients with polymyositis than in patients with dermatomyositis. Muscle biopsy can be diagnostic as well. Treatment involves steroids. So this is about polymyositis. First, clinical findings. It it first presents with a difficulty with tasks which involve proximal muscles. So yes, initially it involves difficulty with all the tasks which involve proximal muscles like combing hair, lifting the objects, or getting up from the chair. And this weakness is usually symmetric and diffuse, and it involves proximal muscles of neck, shoulder, hips, then trunk and thighs. And lower limb muscles tend to be clinically symptomatic first, and then there is weakness, there is fatigue, there is myalgia, there is muscle cramps. So there is fatigue, myalgia, and muscle cramps. Investigation, uh, creatine kinase would be raised in polymyositis. Creatine kinase is raised with proximal muscle weakness. So yes, first is elevation of creatine kinase, then aldolase levels may also be raised. Then we will find autoantibodies like anti-Jo1 in polymyositis, autoantibodies like anti-Jo1. Okay, then muscle biopsy. So creatine kinase raised, aldolase levels may also be raised, then autoantibodies like anti-Jo1, then muscle biopsy is diagnostic. Muscle biopsy is diagnostic in polymyositis. Now treatment involves steroids. Now coming to the chart, here we can see presentation. There is symmetrical and diffuse muscle weakness, proximal more than distal. Second, difficulty rising from low chair, climbing steps, lifting objects, combing hair. Investigation is increased serum creatine kinase, anti-Jo1 autoantibodies, increased aldolase and LDH level, electromyography, muscle biopsy is a definitive diagnostic test. Treatment is with steroids. So this is about polymyositis. That presentation is proximal muscle weakness, which is symmetric and diffuse. Proximal muscle weakness, which is symmetric and diffuse. So proximal more than distal. There is difficulty in tasks which involve these proximal muscles like combing hair, lifting objects, getting up from a chair, climbing steps, and lower limb muscles tend to be clinically symptomatic first. That is also there, so climbing steps may be difficult. Diagnosis is by raised creatine kinase, muscle biopsy, which is a definitive diagnostic test, raised aldolase levels or LDH levels as well, anti-Jo1 autoantibodies positive, then electromyography can be done. So yes, it involves muscle, so muscle biopsy and electromyography. Muscle biopsy is most definitive diagnostic test. Treatment is with steroids. Let's move ahead now. See, in polymyalgia rheumatica, ESR, CRP are raised. ESR raised more than 30, CRP raised more than 6, but creatine kinase is normal. Now let's move ahead. Next, we have a 47-year-old woman who has pallor followed by bluish discoloration of her hands when she goes out in the cold. She has been suffering with this discoloration for the past 3 years. She has symmetrical peripheral arthropathy, which has been present for the last year. She also has small pink and red spots on her lips and her fingertips. What is the single most likely diagnosis in this case? So, this is a case of limited systemic sclerosis or limited scleroderma. But this is not a clear cut question, and the most likely diagnosis here is limited systemic sclerosis. Now, both limited and diffuse systemic sclerosis they may present with pain in hands when exposed to cold, that is Raynaud's phenomena. The classical features of Raynaud's phenomena are episodic pallor of the digits due to ischemia, followed by cyanosis due to deoxygenation, then followed by redness with pain and tingling when there is reperfusion. So that is those are the classical features of Raynaud's phenomena. Pallor, cyanosis, then redness. First, episodic pallor of the digits due to ischemia, followed by cyanosis due to deoxygenation, followed by redness with pain and tingling, which is due to reperfusion, yes. Now, the presence of pink and red dots on the lips and tips of the fingers represent telangiectasia, which is seen as part of the CREST syndrome in limited systemic sclerosis. These are visibly dilated blood vessels which appears on fingers, palm, face, lips, and chest. The presence of pink and red dots on the lips and tips of the finger usually represent telangiectasia, which is a part of CREST syndrome in limited systemic sclerosis. These are visibly dilated blood vessels which appear on fingers, palms, face, lips, and chest. Arthralgia is usually seen more in diffuse systemic sclerosis, which goes against the answer of systemic limited systemic sclerosis. In limited systemic sclerosis, the complaint is usually the occasional joint stiffness rather than arthralgia. However, given the slow progression of the disease and no other features of organ involvement, limited systemic sclerosis is likely the answer because organ involvement is more severe in diffuse type. Rheumatoid arthritis is also a potential differential because it is another cause of Raynaud's phenomena and it would explain the symmetrical peripheral arthropathy. Nonetheless, rheumatoid arthritis is a rare cause of Raynaud's phenomena and it is even rarer cause of telangiectasia. Given the question, the best answer still remains as limited systemic sclerosis. So we should not just be clear with the difference between limited and diffuse. We also have to differentiate it from other conditions like rheumatoid arthritis, which can also lead to Raynaud's phenomena. So we have to understand if it is diffuse, then trunk and proximal limbs involved, rapid onset, poor prognosis, SCL70 antibodies, ANA positive. If it is limited, CREST syndrome, face and distal limbs, and trunk is not involved, slow onset, anti-centromere antibody, not anti-SCL70. There is anti-centromere antibody positive, calcinosis, Raynaud's phenomena is visual dysmotility, sclerodactyly, and telangiectasia. That is about it. So the clincher for this is the timing between Raynaud's phenomena and skin signs. If it is more than 1 year, then it is limited scleroderma or crest. If it is within a year, then it is diffuse scleroderma. Yes, the skin changes in diffuse scleroderma, the skin changes occur within 1 year of Raynaud's phenomena, whereas in limited scleroderma or crest syndrome, skin changes occur more than 1 year of Raynaud's phenomena. Timing is more than that between skin signs and Raynaud's phenomena. Apart from this time between skin science and Raynaud's phenomena, we also have to see the involvement. In diffuse scleroderma, it involves trunk and limbs, whereas in limited scleroderma crest syndrome, it involves only limbs and face. It does not involve trunk. So, classical features of Raynaud's phenomena are episodic pallor of the digits due to ischemia. First, episodic pallor of the digits due to ischemia, then followed by cyanosis due to deoxygenation, then followed by redness with pain and tingling, which is due to reperfusion. Now, the presence of pink and red dots on lips and tips of the finger, they represent telangiectasia. Now, we know in CREST there is calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. This telangiectasia is this appearance of pink and red dots on different parts, and this is seen as a part of CREST syndrome, which is limited systemic sclerosis. These are visibly dilated blood vessels which usually appear on fingers, face, palms, lips, and chest. Now, arthralgia is more commonly seen in diffuse systemic sclerosis as compared to limited, but here there is slow progression of the disease and there is no other features of organ involvement. So, limited systemic sclerosis is likely the answer. And in limited systemic sclerosis, the complaint is usually occasional joint stiffness rather than arthralgia. So, rheumatoid arthritis could also be considered as a potential differential, but it would not explain the telangiectasia because it is a even rarer cause and rare cause of Raynaud's phenomena as well. Although it would explain arthropathy, symmetrical peripheral arthropathy, but yes, the best answer still remains limited systemic sclerosis. Let's move ahead now. Next, we have 55-year-old man who has numbness in hands and feet. His medical history is significant for an asthma associated with nasal polyps and facial pain. Eosinophilia was shown on his last blood test. Pulmonary CT scan shows ground glass inflammation. What is the single most likely diagnosis? So the diagnosis here is Churg-Strauss syndrome. The main manifestations are asthma, eosinophilia, and lung involvement. The incidence of Churg-Strauss syndrome is rare, thus it is also rarely asked in the exam as well, but we might see this topic every now and then. Let's quickly go through Churg-Strauss syndrome. Churg-Strauss syndrome, it is a rare diffuse vasculitic disease affecting coronary, pulmonary, cerebral, abdominal, visceral, and skin circulation. The vasculitis is affecting small and medium-sized arteries and veins and is associated with asthma. The cardinal manifestations of Churg-Strauss syndrome are asthma, eosinophilia, and lung involvement. So, cardinal manifestations are asthma, eosinophilia, and lung involvement. It is a rare diffuse vasculitic disease affecting coronary, pulmonary, cerebral, abdominal, visceral, and skin circulations, affecting small and medium sized arteries and veins associated with asthma. So, the six criteria for the diagnosis of Churg-Strauss syndrome is first, asthma, second, eosinophilia, third, paranasal sinusitis, fourth, pulmonary infiltrates, then histological confirmation of vasculitis with extravascular eosinophils, and mononeuritis multiplex or polyneuropathy. So asthma, eosinophilia, paranasal sinusitis, pulmonary infiltrates, vasculitis, and polyneuropathy. These are the six criteria given by American College of Rheumatology for diagnosis of Churg-Strauss syndrome. Asthma, eosinophilia, pulmonary asthma, eosinophilia, paranasal sinusitis, pulmonary infiltrates, vasculitis, and polyneuropathy. Presence of 4 out of these 6 has got high specificity and sensitivity for the diagnosis of Churg-Strauss. Most prominent signs and symptoms: pulmonary asthma, upper respiratory tract, allergic rhinitis, paranasal sinusitis, nasal polyposis, cardiac involvement, heart failure, myocarditis, myocardial infarction, skin nodules and purpura, renal glomerulonephritis, peripheral neuropathy. So, pulmonary asthma, upper respiratory tract, allergic rhinitis, paranasal sinusitis, and nasal polyposis, cardiac involvement will include myocarditis, heart failure, and myocardial infarction. So, heart failure, myocarditis, and myocardial infarction. For skin, we will have skin nodules and purpura. For renal, we will have glomerulonephritis and peripheral neuropathy. Investigations would be anti-neutrophil cytoplasmic antibodies (ANCA), PANCA positive in Churg-Strauss syndrome, anti-neutrophil cytoplasmic antibodies (PANCA), anti-myeloperoxidase antibodies, perinuclear staining. Then elevated ESR and CRP, eosinophilia, anemia, increased serum IgE levels, chest X-ray will show pulmonary opacities, pulmonary infiltrates, bilateral consolidation. CT scan will show ground glass attenuation, biopsy will show necrotizing granulomas as well as necrotizing vasculitis. So investigation for Churg-Strauss: PANCA positive, anti-neutrophil cytoplasmic antibodies, anti-myeloperoxidase antibodies, perinuclear staining positive, then eosinophilia and anemia on full blood count, eosinophilia and anemia, then raise CRP and ESR, increase serum Ig levels, chest X-ray will show pulmonary infiltrates, pulmonary opacities, and multifocal bilateral consolidation. High resolution CT scan will show ground glass attenuation. Biopsy will show necrotizing vasculitis and small necrotizing granulomas. So ground glass attenuation in CT scan is also characteristic of Churg-Strauss syndrome. Now let's move further. Let's go to the next scenario. Next, a 79-year-old woman started on prednisolone 60 mg for a recent diagnosis of giant cell arteritis. She is asked to take omeprazole for gastric protection. She reached menopause at the age 49. No history of fractures. Her recent DEXA scan shows a bone mineral density T score of minus 3.1. Which medication is the most appropriate medication to add? So, treatment for giant cell arteritis is a long-term use of prednisolone, which puts her at risk of osteoporosis. The dose of prednisolone is high and it is tapered off over several months. Treatment with prednisolone is usually required for 1 to 2 years. Therefore, bisphosphonates would be appropriate to reduce the risk of osteoporotic fractures. So, according to NICE guidelines, we have to consider prescribing bisphosphonates to those who are taking high doses of oral corticosteroids long term, which is more than or equivalent to prednisolone 7.5 mg daily for 3 months or longer. In addition to that, she has a T score in the range of osteoporosis. So here we will study about risk assessment of osteoporosis. So treatment for giant cell arthritis is long-term use of prednisolone, which puts her at risk of osteoporosis. Dose of prednisolone is high. It is tapered off over several months, and the treatment with prednisolone is usually required for 1 to 2 years. Therefore, bisphosphonates would be appropriate to reduce the risk of osteoporosis, osteoporotic fractures. Even according to NICE guidelines, they advise to consider prescribing bisphosphonates to those who are taking high dose of oral corticosteroids on long-term treatment. So that is more than or equivalent to prednisolone 7.5 mg daily for 3 months or longer. So anybody who is taking more than or equivalent to prednisolone 7.5 mg daily for 3 months or longer, they should be prescribed with bisphosphonates. And in addition to that, this patient also has a T score in the range of osteoporosis. Talking about osteoporosis risk assessment. Elderly patients, especially women with untreated osteoporosis, are much more likely to sustain a fracture if they fall. Therefore, patients at risk of osteoporosis should be investigated and treated. The risk of osteoporosis include long-term use of corticosteroids, low body mass index, smoking history, heavy alcohol use, immobility, and untreated premature menopause. Again, the risks for osteoporosis include long-term use of corticosteroids, low BMI, then smoking history, heavy alcohol use, immobility, and untreated premature menopause. So these elderly patients, especially women with untreated osteoporosis, they are likely to sustain a fracture if they fall. Therefore, these patients at risk of osteoporosis should be investigated and treated. Now, Q fracture and Q fracture and FRAX. These are the two tools used commonly by GPs to assess the risk of hip fractures and major osteoporotic fractures. So what are the two tools? Q fracture and FRAX. Q fracture and FRAX. These are the two tools commonly used by GPs to assess the risk of hip fracture and major osteoporotic fractures. NICE guidelines suggest that Q fracture is the preferred tool to use. Both tools predict the risk of fractures over 10 years, and patients whose fracture risk is 10% or more based on the risk assessment tools, these are offered DEXA bone scan to measure the bone mineral density, BMD. Once a DEXA bone scan has been performed, BMD is added into the FRAX tool to recalculate the fracture risk, which guides the management. Q fracture cannot be recalculated taking BMD measurements into account. Patient with a bone mineral density on a DEXA scan of less than 2 minus 2.5. Patient with patient with a bone mineral density on a DEXA scan of less than minus 2.5 standard deviation from the mean of a healthy young woman, otherwise known as T score, indicates osteoporosis and bone protection medication would be warranted. So, who should we perform a fracture risk assessment and who should we request a DEXA scan? If the patient is at risk of osteoporosis, do a fracture risk assessment. If more than 10% risk of osteoporotic fracture, do DEXA scan. If more than 50 years plus fragility fracture, do DEXA scan. So, osteoporotic risk assessment, elderly patients, especially women with untreated osteoporosis, they are more likely to sustain a fracture if they fall. Therefore, these patients at risk of osteoporosis, they should be investigated and treated. Now, the risk for osteoporosis include long-term use of corticosteroids. Apart from that, smoking, heavy alcohol intake, low BMI, then low BMI, immobility, as well as untreated premature menopause. Long-term use of corticosteroids, smoking, alcohol intake, heavy alcohol intake, low BMI, immobility, and untreated premature menopause. Q fracture and FRAX. These are the two tools used commonly by GPs to assess the risk of hip fracture and other major osteoporotic fractures. NICE guidelines suggest that Q fracture is the preferred tool to use. Q fracture is preferred. So both tools predict the risk of fractures over 10 years. Patients whose fracture risk is 10% or more based on the risk assessment tools, these are offered DEXA bone scan. And this DEXA bone scan is used to measure the bone mineral density. Once DEXA bone scan has been performed, this bone mineral density is used into the FRAX tools to recalculate actually the fracture risk, which helps in guiding the management. Q fracture cannot be recalculated taking BMD measurements into account. A patient with a bone mineral density on a DEXA scan of less than minus 2.5 standard deviations from the mean of a healthy young woman, otherwise known as a T-score, indicates osteoporosis and bone protection medication should be given. So two tools are there, Q fracture and FRAX. We will use Q fracture, which is a preferred tool to use according to NICE guidelines to assess the risk of fracture. Now, patients whose risk of fracture is more than 10%, patients in which after fracture risk assessment, if we find if there is more than 10% of risk of fracture, risk of osteoporotic fracture, we will do a DEXA scan. Or if there is a person who is more than 50 years old plus there is fragility fracture, we will do a DEXA scan. So in both the cases, in a case in which there is more than 10% of risk of osteoporotic fracture, we will do a DEXA scan. In other case, if more than 50 years of age plus fragility fracture, we will do a DEXA scan. After in DEXA scan, we will calculate bone mineral density BMD. Now this BMD, bone mineral density, is used for FRAX tool to recalculate the risk of fracture, which will help in guiding the management. Now, a patient who is having a bone mineral density less than minus 2.5 standard deviation than a healthy young woman, that is t-score. If t-score is less than minus 2.5 standard deviations, then that person is given bone protection medications and it indicates osteoporosis. So on a DEXA scan, which is used to calculate bone mineral density, if bone mineral density on a DEXA scan is having a t-score of less than minus 2.5 standard deviations, less than or equal to minus 2.5, less than minus 2.5 standard deviations from the mean, it indicates osteoporosis and such individuals should be given bone protection medications. So this is about osteoporosis risk assessment, and now we'll take a break here and we'll resume the session in a while.